those of you, okay. So good afternoon, everybody. For those of you who I haven't met, my name is Britt Nicholson. I've been a physician here at MGH for 42 years, and I'm currently a senior vice president of the development department. And I'd like to welcome you to our web seminar series on COVID-19. It's called MGH Answering the Call. We have about over 300 participants in this webinar this afternoon. And I want you to know that you don't need a microphone or video capabilities to participate. At any point during the webinar, you can ask questions. You can ask questions anonymously if you want, using the Q&A feature that's at the bottom of your screen. And this webinar will be recorded, and a shareable link will be provided after the event. Before I sort of announce the speakers this afternoon, I just want to inform you with a bit of remarkable news that we got just within the last half an hour. We received a phone call from the Hearst Foundation that they have authorized a gift of $1 million to our emergency response fund. And what's even more remarkable is that in a special meeting of the board, that foundation has allocated $50 million to over 100 institutions throughout the United States for battling this pandemic. So again, a great note of thanks for the Hearst Foundation for this welcome gift. So our speakers this afternoon will include Peter Slavin, who is a president of the hospital, Dr. David Brown, who is chief of our emergency services, Dr. Joe Betancourt, who is vice president and chief equity and inclusion officer, and Joan Quinlan, who is head of our Center for Community Health Improvement. So now, Peter, I'll turn the microphone over to you.
Thank you very much, Britt, and thank you all for joining us this afternoon for this webinar. Like Britt, I've been associated with the MGH for a number of years. I'm celebrating my 35th anniversary on the staff, and I've been proud of to be associated with this hospital every day over those 35 years. But I can honestly say I've never been more proud to be associated with this institution than I have been over the last few weeks. The response of our staff to this global pandemic has truly been inspirational and as you'll hear, quite robust. And so it's been a very moving experience for me, and I know people throughout this organization. Now, dealing with our country's most pressing healthcare emergencies is nothing new to Mass General Hospital. We responded in force to the tragic explosion that occurred in Halifax Harbor a number of years ago. We were very involved in relief efforts related to the Spanish flu, very involved in our country's healthcare needs with 2 world wars, very involved in responding to the terrible Coconut Grove nightclub fire that happened in Boston. And as I'm sure you'll recall, not too long ago, responding to the tragedy after the Boston Marathon a few years ago. So emergency preparedness is nothing new to the hospital. We practice our emergency preparedness activities on a regular basis, and we began preparing for this pandemic back in January. Just a little bit about the biology. As you all know, this new virus, which is SARS-CoV-2, originated in Wuhan, China, and has spread around the world. Roughly 600,000 people in the United States have been infected by it, although that is probably a gross underestimate because there are a number of people who are asymptomatic and a number of people who've never been tested even with symptoms. Here in Massachusetts, there are about 30,000 people that have been affected by this virus. At least those are the confirmed positive cases. We have been steadily seeing increasing number of patients at the hospital over the last month or so. And as of 3 o'clock this afternoon, we currently have 328 patients in the hospital with confirmed COVID-19. COVID-19 is the disease caused by SARS-CoV-2. And of those 328, 144 of them are sick enough that they need to be in one of our intensive care units. There are another 106 patients in the hospital with suspicious symptoms of COVID-19, and they're in the process of being tested. So when you add those together, it's slightly over 400 patients that we're currently caring for. Now, under normal circumstances, we would have one intensive care unit available to care for patients with viral pneumonia. Viral pneumonia is the most serious symptom and problem that SARS-CoV-2 or COVID-19 causes. At this moment, however, we have 10 intensive care units that are caring for these patients. Not only the medical intensive care unit, but a number of our specialty units have joined the fight. And we've also been able to convert several general care units, including 2 in the Lunder building, into ICUs as well. This is a very serious disease. The mortality rate is probably about 14 times that of influenza. And so we've seen a lot of very sick people, but a lot of them have gotten better, some very quickly and some over a more extended period of time. I visited our medical intensive care unit yesterday to talk to the staff and thank them on behalf of the institution for what they're doing. And they were quite ecstatic because one of the first COVID-19 patients that they admitted several weeks ago initially was put on a respirator, then was not getting enough oxygen in his blood, even being on a ventilator, and so was put on something called ECMO, which is a machine that oxygenates people's blood when their lungs are unable to do so. This patient was on ECMO for 2 weeks, which is an extraordinary occurrence. He then was able to get off of ECMO a few days later, off of the ventilator, and he was about to be transferred to one of our general care units. And when I walked by his room, he was actually FaceTiming his children. It was an incredibly moving experience for me to see what the really hard work, dedication, and expertise of our staff can result in. Now, as I said, we have been seeing a steady increase in the number of patients that we are caring for, but I'm pleased to report that the curve that we're seeing has definitely slowed down. In the first couple of weeks of this epidemic, our number of patients was doubling every 3 or 4 days, but over the last week, our number of patients has gone up by 35%, and on a day-to-day basis, it's now just a couple of percentage points. And so we have our fingers crossed that we are nearing the flat of the curve and that this wave will begin to go down. And that's not only our experience, it's the experience across our health system, Mass General Brigham, as well as other hospitals in the area. So we have our fingers crossed that we are near the peak of this particular wave. I thought I'd just say a word or two about testing. We were one of the first hospitals in the area to start testing for COVID-19. It involves a test called PCR, which measures viral RNA in the blood of patients with symptoms. And we're now doing about 500 tests a day and can turn those tests around within a matter of hours. So we're able to meet all of our internal testing needs. We are also about to bring online antibody testing, which can be used to identify people who are beginning to recover from COVID-19 and are beginning to develop antibodies and immunity against the disease. And that will be very helpful in determining who's had the disease and also identify people who could potentially give their blood, their serum, to treat people with suffering from the disease currently. Now, one of the other big issues that we've been dealing with is personal protective equipment. I know Dr. Brown is going to comment about that a little bit later. But I think another amazing thing that our organization, our health system, has done is to contract with a company called Betancourt and create a unit that can decontaminate the most precious piece of personal protective equipment, namely N95 masks. And that facility is up and running in Somerville and has the capacity to decontaminate 80,000 masks a day, which is far more than we produce. In fact, it's probably more than all the hospitals combined in Massachusetts are using on a daily basis. So that facility is going to be a game changer in terms of our PPE supply, at least for that one item. Another thing that's happened across our health system and with the help of a lot of people from the MGH is that we've stood up a 500-bed subacute unit at the Boston Convention Center. That unit is known as Boston Hope. Our own General Jack Hammond, who up until about a little more than a week ago was running our home base program, is now in charge of Boston Hope. He's been joined by Jeanette Ives Erickson, our former chief of nursing, who is leading the nursing effort at Boston Hope as well. And that unit is now seeing, I think there are about 50 patients that are being cared for with the potential to go up to 500. If that weren't enough, there has also just been this incredible innovation activity that's occurred within the organization over the last few weeks. We actually stood up across Mass General Brigham an innovation center, and one of the leaders of that center is Dr. Gary Tierney from our Wellman Center. That innovation center has been examining all sorts of new technology that's out there that has the potential to help us in our fight against COVID-19, things like using 3D printing to make N95 respirators or face shields, or there's a number of individuals, companies that are trying to produce these novel ventilators, and so they're evaluating those types of technologies as well, and making recommendations to us and to the state, for that matter, about which of these technologies is really good to go. If that weren't enough, there is also just an enormous research effort that is underway within our health system, and including at Mass General Hospital. We are doing multiple drug trials as we speak on drugs like remdesivir, drugs like favipiravir. We're doing trials on drugs that inhibit IL-6, which is a chemical involved in the inflammatory response. We're involved in trials using a gas called nitric oxide to see if by relaxing the pulmonary circulation and perhaps killing the virus, that gas can help patients with COVID-19 as well. So the list of trials just goes on, and we've created a special group led by Keith Flaherty, who normally works in our cancer center, to evaluate the potential trials, prioritize them, and then make sure that they get implemented. And that's going extraordinarily well. I guess I just want to close by saying that it's been overwhelming to see what's happened within our organization, but it has also been incredibly heartwarming to see the kind of outside support that we've been getting, ranging from a package that I received in my office yesterday from a young girl from upstate New York who explained in a letter that she felt badly that her new 3D printer hadn't arrived yet, but in the meantime, she had made a series of handmade masks that she wanted distributed to our staff. We've also received countless food donations from restaurants, individuals in the area wanting to provide meals to our staff. And we've also received extraordinary philanthropic support, including the gift that Britt mentioned a few minutes ago, which we are just incredibly grateful for. And we are going to be using that support in a variety of different ways to help pay for hotel rooms for our staff, to help buy some of the equipment that our lab is needed to bring on testing, and a number of other ways that we will use those philanthropic funds to help our staff and our patients get through this difficult period in a less difficult way. So I want to thank all of you who have joined us this afternoon, and I know many of you on the phone have already supported our efforts, for which we are deeply grateful. And I will look forward to your questions a little bit later, but will now turn I'm not exactly sure what I should turn. Is it the floor, the podium, or the screen over to David Brown, the Chief of our Emergency Department. Thank you all so much.
Thank you, Peter, and thank you for that summary. Really a nice summary of our pandemic response, from evaluation and management to investigation and treatment to prevention. I'm going to take a more narrow focus and give you a perspective from the front lines. As you heard, I'm Chief of Emergency Medicine, and I too have been at MGH for a little while, having arrived here in 1989 as an intern, and have played pretty much every role a physician, I think, can play in the institution over my 31 years. The last 29 years I've been in emergency medicine, And this report really comes from the front lines of the pandemic response. So just to recapitulate some of the numbers that Peter started with, in the US, there are now more than 640,000 confirmed cases. And as was mentioned, that vastly understates the penetrance of the disease because of variability and limitations with testing. In Massachusetts, again, there are about 30,000 confirmed cases, also massively understating what we all believe the true rate of infection has been. Mass General Brigham, not surprisingly, has been on the front line of responding. And as was mentioned, I think earlier, there are more than 800 patients hospitalized across the Mass General Brigham system. And it probably surprises none of you that MGH has done its part, more than its part. 340 of those 823 patients are hospitalized at Mass General, with 104 in the intensive care unit. And the vast majority, 95% of those patients in the intensive care unit, are on ventilators. And just to give you a sense of our normal acuity for this time of year, normally in the middle of April, at any given time, we'd have about 45 to 50 patients on ventilators, sick enough to be on ventilators in one of our intensive care units. So 144 is a massive upgrade in our capability and has stressed our system. But as was mentioned by Peter, the flexibility and innovation of our critical care teams has been extraordinary, and it's been amazing for me to watch from my perspective. Down on the front, on the first floor in the emergency department, we have seen an enormous uptick in COVID acuity and in volume and intensity as we near the peak. Yesterday, I rounded with Dr. Slavin through the emergency department. And I'm used to this, but I don't think Peter is. The team was getting ready to intubate their 8th patient. There were multiple other patients intubated and on their way to the ICU. Just to put it in context, 8 intubations before noon in the pre-COVID era would be unheard of. A normal day in an emergency department the size of ours would be 1 or 2, maybe 3 intubations, but 8 on the day shift would be unheard of. And that's the kind of severe respiratory failure that the small percentage of patients who are infected with COVID-19 do develop. So I was asked to reflect on the things I worry about from the perspective of emergency medicine and the front lines. I would say that there are really 2 major things I've worried about in our response to the pandemic. The first and most important is meeting the needs of our community in the face of unprecedented demand for care. Perhaps many of you have heard that in 1811, when Mass General was founded, it was founded on a principle that when in distress, every man and woman becomes our neighbor. And this is especially true, I think, in emergency medicine and in the MGH emergency department, where we take care of men and women in distress and treat them as our neighbor. But it becomes even more true during a disaster. And COVID is the ultimate disaster that has stressed our system and our community for weeks. So what keeps me up at night and has for weeks is, will we have enough capacity? Will we have enough room in the emergency department? Will we be able to stand up enough ICU beds? Will we have enough ventilators to care for our community as the peak arrives? Or will we have to invoke the unthinkable, so-called crisis standards of care that you probably saw written about in the Boston Globe last week? The second thing that I worry about that keeps me up at night is the unique issue posed by the COVID disaster, and that is the threat to our staff. Most of the time when we respond in the emergency department to sick or injured patients, even if it's a large volume, we're not concerned for ourselves. But that's not the case with COVID-19. And keeping our staff healthy and protected has been one of the major things I've worried about during the unfolding and increasing intensity of the pandemic. Will we have enough personal protective equipment? Will we be able to source enough to keep our teams safe and healthy so they can do the job they need to do? Will we have time to train providers in proper donning and doffing of protective equipment as more and more units and floors at MGH become COVID floors, and providers who are not used to taking care of infectious diseases have to be brought up to speed on that process in order to protect themselves? So those are the 2 major things that I've worried about during the unfolding of the pandemic. However, the good news is I think there's a lot of cause for optimism at this juncture. And I'll describe a few of my thoughts about that. The first is that our staff has remained remarkably healthy. Some of this is good fortune. Some of it is really great training. No frontline emergency department nurse or doctor at Mass General has become infected to date. That is really remarkable. And the small number of other ED staff, frontline staff who've been infected are all recovering, and most are already back to work. The second major cause for optimism is that we're meeting the demand of our community, and our modeling suggests, as Peter mentioned, that we will in fact have enough staff, enough supplies, enough ventilators, enough medication to meet the surge. The curve is indeed flattening now, and we appear to have enough ICU capacity. And with the peak just in front of us, we'll know very soon. And the last major cause for optimism are the daily incredible displays of courage, teamwork, resolve, commitment, and resiliency that I see in my emergency department teams every day, that I see in the ICU when I round there, that I see in the respiratory illness clinics, and that we see in the efforts to stand up alternative treatment centers like the one over in the convention center. Here in the Mass General Emergency Department, I watch my emergency department teams place themselves into COVID hot zones day after day, shrugging off the risks themselves and committed to serve our community in its time of need. Now, I would expect nothing less, but it's still incredibly inspiring for me to witness it day after day. We are proud as a department to step forward and serve our community at this time and in this place. And as I've said to many of you on the call and many colleagues, there's really no place I'd rather be during any major event, but certainly during this pandemic, than in the Mass General Emergency Department. Last thing I was asked to talk about was what to expect in the days and weeks ahead. And that's a larger discussion than we have time for today, but I expect continued flattening of the curve with gradually less disease prevalence in our midst, a cresting of the demand for hospital-based resources, and then hopefully thoughtful discussions of how and when to reopen our society and our healthcare system. I also expect that we will develop some data-proven therapies, not espoused by political figures, but data-proven therapies. And looking further ahead in 2021, I hope that we'll have the successful development and widespread distribution of a vaccine. So I'll turn it over to Dr. Betancourt in a minute, and I'll just make one other comment. In my specialty, emergency medicine, our mantra is anyone, anything, anytime. During disasters and pandemics here at Mass General, we extend that to everyone, everything, every time. And I really thank all of you for supporting us so that we can do our best to support our community. And with that, thanks, I will turn it over to Joe Betancourt, who's our Vice President for Diversity, Equity, and Inclusion.
Great, thank you, David. And thanks, Peter, Britt, and it's a pleasure to be on with my co-conspirator for years, Joan Quinlan. We've had a chance to be partners in this work. I'm a practicing internist here at Mass General. I've been here since 2001. I do about 20% patient care. I'm originally from Puerto Rico, Spanish speaker, so about 75% of my patients here, my panel, are Spanish speaking. And so the topic I'm going to be sharing with you here today is near and dear to my heart. And certainly it's one that if you've had any chance to even see today's Boston Globe, will, I think, resonate. And part of what I'm here to share is a tale of two cities. We have great news in certain parts of our state, but really very different news in others. And I wanted to talk a bit about that. And I'm thankful to say that we had, to some degree, the ability to have some foresight about how issues related to equity, disparities, and social determinants of health were going to impact us and certainly our country. In newspapers, day in, day out, you're hearing how the COVID epidemic has become an epidemic, a pandemic of communities of color, Black and brown people. And while we certainly think it's important to highlight that, I just want to spend 1 minute giving you a bit of a narrative as to why that is. And then talk a bit about what are the things that we did here to prepare and what we're doing right now. Because what we know today is that as Chelsea, as Revere, as places like East Boston go, so goes Mass General as it relates to our ventilators and all of our work. And that'll make more sense in a couple of minutes. So this is what we know. This has become an epidemic, a pandemic that has disproportionately impacted individuals of color across the nation and certainly in our midst. This is because we know first that individuals from vulnerable populations and minority groups came into this epidemic already with a significant disadvantage. A disadvantage of being impacted negatively by the social determinants of health, low socioeconomic status, challenging environments, lower access to education and the like, higher burden of chronic disease, less access to healthcare, and difficulty navigating the healthcare system even when they have insurance. So this is the backdrop and the foundation upon which a whole set of individuals enters this crisis. Add to that the very unique aspects of this virus, which include very rapid spread during a time when people are asymptomatic. And so you can begin to think about a set of social conditions that create a perfect storm for the spread of this virus and the pandemic that we see today. So those social conditions include areas of high population density. They include areas where they are predominantly inhabited by individuals with lower socioeconomic status, working people who did not have a chance to work remotely, did not have a chance to have groceries delivered to them, are essential workers in many cases, didn't have a chance to drive to work and had to take a bus or a train, all during the time when we were telling people to social distance. And so these sets of conditions really created a perfect storm for the very rapid spread in homes where perhaps in a small amount of square footage, 7 people, a family taking care of a grandmother and aunt, all living together, really created a spark, which created embers and a fire, which we've seen spread. And I think the place that you'll hear us talk about the most is Chelsea. Chelsea's rate of COVID, a coronavirus infection, is 159 per 100,000 population. And the next closest is about 100 in Brockton. I'm sorry, in Lawrence, and then right around there in the 90s is Brockton. And so what's fascinating is, just to make my point of a tale to see. So I live in Cambridge. If you look at the population density in Cambridge, it's almost equal to the population density of Chelsea. Chelsea's the most densely populated, but we're pretty close. And our COVID rates are 43 per 10,000 population. So socioeconomic status plays a very, very large role here. And it's not just population density. Now, people of color tend to disproportionately live in those environments. And so I just wanted to frame this out. This is not about any genetic susceptibility or bad actors among these communities. And I think, again, we see across our state this exact issue play out, as we see with African Americans in Detroit, Chicago, Milwaukee, New Orleans, as we see with Latinos and African Americans in Queens. So this is the epidemic and the pandemic that we're facing, particularly as it relates to equity. So what have we done? 4 weeks ago, we began to think about this. We began to think first that we communicate with many of our patients through our electronic record, yet we know a lot of our patients from these communities don't have access to that. Same goes for our employees, for whom we communicate a lot via email, and they don't have access to email. So we've launched a text platform to get to all patients and employees in 5 languages to keep them updated on policies, practices, ways to access our services. I'd say that's number 1. Number 2, we have translated all of our materials into multiple languages focused on disability. We have built language services into everything we've done. So we've tried to democratize all of our different services and aspects of communication here on campus. Number 3, we created something called a multilingual registry so we could identify doctors, nurses, frontline staff who spoke another language, with the idea that speaking another language is an asset when people are going to be redeployed. How have we redeployed that? On Monday, and again, this is in the Globe today, we launched something we call the Spanish Language Care Group. 50 doctors who speak Spanish, native Spanish speakers, across multiple disciplines in our institution, who now fully staff 24/7 all the COVID wards. We just assigned a doctor now to the emergency room as well. So it's 6 doctors on each of the COVID teams altogether, a doctor in the emergency room, and 3 doctors overnight covering our units. What does this do? These doctors are not interpreters. They bring clinical, cultural, and linguistic competence to help the teams work more efficiently and not overburden our interpreter services. Next is our work in community health. Our work in community health has been amazing. We've been trying to really think about how we address this pandemic in the communities that I mentioned. And it really is 4 steps, and Joan will bring this to life as we've animated those steps. We've executed on those steps in Chelsea, but are working with other communities in these areas. They include, number 1, identification. How do we do a better job of identifying people who are infected, and also do that by increasing testing and broadening criteria? Number 2, mitigation. How do we decrease the spread? How do we deliver high-touch, door-to-door kits that include masks, sanitizer, wipes, so that people, despite their social condition, can do the best they can to protect themselves and their families? Number 3, isolation. How can we take individuals who are positive, who are at a risk to their families if they go home in crowded situations, and put them in a safe place where we could watch them, they could convalesce, and they could improve or end up in the hospital, either way, but we are giving them that care away from a place that leads to more spread. And then finally, communication. How can we continually communicate with these individuals from communities using a variety of different tactics? I'll now pass it over to Joan. I'll just say that we are honored by what we've been able to do. We definitely have incredible needs, and I believe that all the technology and all the science that we do is phenomenal. But at the end of the day, as these community goes, so go we. And those sets of social conditions are the ones that we are challenged to address as in the time of crisis, every man and woman is our neighbor. On to Joan.
Thank you, Joe. And thank you, everyone, for joining this session. So let me just elaborate a bit. First of all, just by way of background, I want to say I am proud to work at an institution with such a history of commitment to the community. As David Brown mentioned, it's in the founding mission statement. It is in today's mission statement, somewhat unusual for an academic medical center. We have a board committee on community health because our trustees care so much about it. We 50 years ago founded 3 community health centers in low-income communities, and 25 years ago, when I joined, there's a lot of longevity here, we formed the Center for Community Health Improvement. And by way of background to this story, the center focuses primarily on social determinants of health. And what are they? They are things like access to healthy food, access to family supporting jobs, educational attainment, affordable and safe housing. And you might be wondering, well, what's a health system doing focusing on those things? And fact is that it's 10 to 20% of your health status is determined by access to quality health care. The remainder, 80% or thereabouts, is determined by these social determinants. What are the conditions where you live and spend time? And it is no accident that Black and brown people are more likely to live in the communities with these negative conditions that have a negative impact on your health. And if you ever doubted the reality or the importance of social determinants and its impact on your health, this pandemic has to eliminate all doubt. Because as Joe pointed out, I want to focus in particular on Chelsea and just put a point on the conditions that Joe mentioned. Overcrowded housing. So we have a tendency to counsel people if they've been exposed or if they've been diagnosed, isolate, stay home, and even stay away from your family, kind of isolate within your own home. That is not an option for the families in Chelsea who double up often in small overcrowded apartments with 1 bathroom. That is just not an option. And the essential workers that Joe mentioned can't afford to stay home and often take public transportation. So you see the conditions for spread in these communities are deep. So Chelsea is a community that is right across the Tobin Bridge from Mass General main campus, really only about 2 miles away. And we have had a health center there for 50 years. So a couple of things happened in this story. First, Joe and other physicians noticed that about 40% of our inpatients who were COVID positive were limited English proficient, and about and the vast majority of them were Spanish speakers. And then we started getting the data from the state that put Chelsea by far at the top. So what have we been doing? We've been partnering with the city of Chelsea, and I really want to put a point on that. We don't kind of come into town and say we're the experts and we've got all the answers. We are experts in some things, but we are partnering with city leadership and community-based organizations. And I have to say the city leadership of Chelsea has been outstanding in developing a comprehensive plan, mobilizing that community. So if we go through the outline that Joe gave, identification, we expanded testing so that in the first day that we did, we have what's called a respiratory infection clinic at our MGH Chelsea Health Center. The first day they expanded testing criteria, they tripled their testing. 50% of the people they tested were positive. And I believe that the usual rate is somewhere on the order of 10% of those tested are positive. So, and we believe that testing is important as a mechanism for tracking who is positive and then who are they in contact with and what do they need so that we can contain the spread of the disease. So that's one. Two is isolation. So the city of Chelsea, along with the city of Revere, did an outstanding job as contracted with a 145-room hotel and standing that up today. As a matter of fact, I believe it's opening its doors, or maybe officially tomorrow. And Mass General is completely putting in place, no charge to anyone, 24/7 medical support for that facility. They could not put up this operation without that support. Additional mitigation, this is number 3. We are making available, and actually they're out on the street now, they will all be distributed throughout the city of Chelsea, 25,000 masks. So if you can't isolate, the next best thing is to take some protective measures. Those masks come with English and Spanish instructions about how to stay safe. We also were able to get some soap, hand sanitizers, hard to come by. And there's a massive distribution network going on in the city as we speak. 2 more, we are sending a cadre of MGH volunteers to help the city public health nursing do some of that contact tracing and reach out to high-risk people and counsel and get some of those supplies to them as well. And finally, we are addressing social determinants. Our Center for Community Health Improvement is helping to really organize a massive food distribution effort throughout the city, and has also brought Fresh Truck to our highest risk patients at MGH Chelsea. So we don't claim to have all the answers. This is an immediate emergency response. And when these all hit the ground by tomorrow or Saturday, we'll be looking for what do we need to be doing next, and how do we bring what we've learned from Chelsea to the other vulnerable communities, with Revere being probably next up. So with that said, I will hand it, I believe, back to Britt.
Thanks very much. Thanks very much to all of you. So we've gotten several questions that have come in. The first one is one that I'm sure is on everybody's mind, and I'll direct this one to both Peter and David. The question is, understanding that no one has a crystal ball, as medical professionals, what does returning to normalcy look like? What are the phases? Are there any objective criteria for each phase? And what's your best estimate of a possible timeline for each phase?
Yeah, that is the question of our lifetime, I think. And I certainly don't pretend to have a crystal ball, but you've heard about the large numbers of people in this country that have been infected, the large numbers in our state. But nationwide, nationwide there are about 300,000 or 600,000 people that have been infected, but that's only 0.2% of the US population. Here in Massachusetts, which has been one of the harder hit states, it's only 0.4% of the population that has been documented to be infected. Now, we think those estimates are dramatically low. We think the actual numbers are significantly higher than that because of the unavailability of testing and because so many people with this disease are asymptomatic throughout its entire course. But even if those numbers are off by a factor of 20, let's say, that means that maybe 4% of the people in our country have been exposed to COVID-19. Herd immunity, which is what we ultimately need to achieve to stop the spread of this illness, doesn't occur until 60% of the population will have been exposed. And in the absence of a vaccine for a year, and in the absence, at least at the moment, of an effective treatment, how you get that 4% to 60% without a lot more deaths and without overwhelming the healthcare system is a daunting challenge. Obviously, younger people are less susceptible to this disease than older folks, so you may want to start by loosening up the social distancing for younger people. It would be really helpful if we had more testing available and could tell who had had the infection and give them a pass to go about their lives again. But I do worry that if we let out the leash on our social distancing too quickly, given the fact that the majority of our population hasn't been infected, that we could see a wave develop that will make the one that we're currently living through look like child's play, both from the number of people who will be infected, die from it, but the overwhelming of our healthcare system as well. So as we approach the wave, we are beginning to think about how will we start to reopen various parts of the hospital, and so we're giving increasing amounts of thought to that. One last thing I'll say on this question is that government leaders, we may say that we're going to turn certain things back on, but there's a real question as to whether people will be so afraid that they won't venture from their home despite that. One of the interesting phenomena in our emergency department is, we've seen a big increase in COVID patients, but for unexplained reason, the number of patients we're seeing with heart disease is down by 50%. Number of kids we're seeing is down 75%. Number of strokes we're seeing is down 32%. Presumably, there are a lot of sick people with heart attack, strokes, who've decided at home to stay at home and not because they're fearful of leaving their home and coming into an emergency department. So I think fear is going to play a very big factor in how quickly this situation can get better.
Okay. We have another.
David, you want to say anything further on that?
I think you covered it really well. The only thing I would add is that it's hard to imagine how we could open up our society without broad-scale testing, both for antigen, meaning for the presence of virus, and also for antibody, meaning prior disease and now recovery. Without understanding and being able to monitor closely the prevalence of disease and the degree to which the community is already immune, I think we'd just be flying blind. We may have no choice, but that worries me quite a lot.
Okay. David, I'm going to direct this one to you. Massachusetts has seen a higher disease burden, both on a per capita basis and an absolute basis than other states, many other states. Are there any reasons why this has been the case? And are there lessons that can be applied going forward such that we fare better in a second wave?
Well, I think it's a question. It's a good question that has several answers. We started with a sentinel event, if you will, the Biogen conference, which contributed to the spreading of the disease in our community, which gave us a little bit of a head start. We're also a very cosmopolitan city, and so people travel in and out of it. And we now believe that COVID was spreading through the community for weeks, maybe even months before it came to our full attention. So that's one reason why Massachusetts has had a lot of disease, a recognized disease. The other reason, frankly, is that we've had a pretty coordinated and broad testing capability from pretty early on in the pandemic, and that's not been true in other parts of the country. So I would be kind of wary of those parts of the country that are reporting very few cases without understanding the degree to which they're able to test sick patients and even not so sick patients to understand fully the penetration of disease in the community. And I think the second part of my answer really just goes back to what I just said, and that is that I hope we will be able to test even more broadly as we start to come out of the social distancing policies and bring society back towards some semblance of normalcy so that we can understand where the disease is flaring back up and how we could quickly respond to that.
Joan and Joe, this one's for you. It seems like it took an awfully long time for us to recognize the disproportionate burden that our lower income communities were bearing as a result of this. Can you explain why that happened and what we can do in the future?
You want me to take it?
Sure, you can.
I think that's a very fair point that given what we know about inequalities in health, that we could have planned for it. But honestly, there's no emergency preparedness manual. There will be in the future that is very intentional around equity. And I really do think that this will be a lasting piece. But I would say it was not so long. It actually was fairly early, at least in the Mass General experience, of quickly noting the number of inpatients and quickly looking at the statewide and seeing the trend there and acting on it. I think we may be the only, I don't know this for a fact, one of the few, if not the only, academic medical centers and systems in the country that has stood up a significant equity and community health component of their COVID response. And Joe and I report in, Joe is a leader for the system, and Joe and I report into the MGH a minimum of twice a week of the incident command. So the system's taking it very seriously.
Okay.
Yeah, I would agree. I mean, I think, I look back now and I say, well, we stood this up initially because history tells us that if you look at any epidemic, vulnerable populations always suffer more. If it's Katrina, it's individuals with low SES in low-lying areas where the levees aren't strong. You could name all of these. And I think, we will learn a lot about once we get a sniff of something like this globally, that we should engage in those processes first in places where the social conditions are such that spread will happen rapidly. And, I think the other point I'd make is that sometimes when I look at Chelsea's numbers, they're so high compared to the rest of the state. But as I begin to think about it more, I really think it's because we've had a presence there. I mean, I think we've done a lot of testing. We've been there. We began very early to sound the alarm and say, wait a minute, 35% of our COVID inpatients, even when we had less than 100 early on, were Latino into those communities, and that quickly caused us to pivot. So there will be lessons for the future, I believe, and I think they'll be very important. But I think we acted as quickly as possible once we started, smelling the smoke of the fire and where the fire was coming from.
So David, this one's for you. Why is it that some people with the virus, even very young people, get very, very sick, and some are asymptomatic and do not get sick at all?
Oh, a nice, easy one. Thank you. Well, it's interesting. When our species is exposed to this novel virus, remember, none of us have native immunity the way we do to other viruses and diseases that pass through our communities year after year. So we're all at risk of getting infected. And it seems that while most people have a normal immune response and clear the virus relatively quickly, and in the process have what we would consider to be a mild disease course of fever and respiratory or gastrointestinal symptoms that are mild, muscle aches and the like, and in 4, 5, 6 days start to feel better. There are a subgroup, a small but significant minority of people have an overly vigorous immune response. And it's actually that overly vigorous immune response that causes the lung injury that leads to patients being unable to breathe and having acute hypoxic, meaning low oxygen respiratory failure. Why that minority has that overly vigorous immune response is the subject of intense research right now. We don't even fully understand which of the various immune mediators are most in play here, although we have some clues, and we're now starting to test therapies directed at some of those immune modulators. Interleukin-6 was mentioned earlier, and that seems to be a big player here. But we don't understand why some people mount this overly vigorous immune response, but it does seem to be the key to trying to prevent the lung injury in that group of patients.
And Britt, if I could add just one thing, I mean, I would turn people's attention to an article that was in the New Yorker a couple of weeks ago, which is really fascinating, and it's become a working hypothesis for me about why we see in Chelsea a fair amount of younger people coming in sicker. And it's this topic of viral load. It's this idea that the level of your exposure to this virus, the amount of your inoculation of this virus, might be a predictor of your outcome. Now let's, a casual exposure touching something in the supermarket with not a high viral load might give your immune system a chance to kind of get out ahead of this. Let's go back to Chelsea now. Let's think about a family of, father, mother, 2 kids, a grandmother and aunt, and the father and mother both worked at the hotel where the Biogen conference was. They bring it home, and for 2 weeks they're shedding virus to that entire group of family members, right? So those individuals' level of exposure, while they're asymptomatic, may be a lot higher, and thus that may explain also why we're seeing younger people in certain situations, in addition to the preconditions that we know about, that lead to worse outcomes. Viral load is also something that's being explored, and it's something that I think I've been trying to learn more about, and New Yorker really does a great job of talking about that as well.
So, Joe, I'm going to stay with you for this next question. Given your role with diversity and inclusion, it says, how is or will MGH accommodate cognitively compromised persons contracting COVID-19? Typically, I would accompany him throughout any inpatient stay, as he could not advocate for himself in any way. Thank you.
Yeah, I'll just say, one of the things, a subset of our work was our disabilities task force, right? And we like to call it diverse abilities, this idea that individuals, bring a whole diverse set of abilities with them. And, we think of everything from, cognitive to physical. And I think we've tried to make a lot of accommodations. Certainly we have a no visitor policy, but we've been very thoughtful about what that looks like for somebody who's hard of hearing or visually impaired or with cognitive delays. And, we understand the importance of these exceptions and the need, quite frankly, to protect anybody who comes in as well and protect our staff around certain exposures. But, I think we've been very thoughtful, whereas we may have blanket policies, that are forward facing. We understand that this isn't a one size fits all. And I think we've been pretty proactive about reacting, and a very vocal group of individuals who've been supporting those communities. So I've been proud. I think there's always more that we could do, but suffice it to say that if you were to come here to Mass General, if you were to raise this issue, you would have a team who would try to help solve that problem for you.
Okay. So Peter, this is from someone you know well, a former general director of the hospital, Charlie Sanders. So Charlie, welcome to the webinar. Charlie wants to know whether we have enough test kits now.
Hi, Charlie. I presume you're in either North Carolina or Cape Cod, but it's great to hear from you, and hope you and your family are well and stay that way. We, like I said before, are meeting the needs of our own patients and staff, including the demand that's coming from places like Chelsea. But we could do even more testing if we had more supplies. We need more of the swabs that are used to collect the samples from patients, and we also need more of the kits that laboratory manufacturers like Cepheid or Abbott make that we use to run the tests on our machines. So more testing with more availability of those supplies would be an even better state than we're in now. And I think dramatically more testing is going to be required, both antigen and antibody testing, to find a reasonably safe path out of the current shutdown of our society.
Okay. And Peter, this question really follows on that. It says, can you talk a bit about how we would plan to initiate antibody testing?
Well, antibody testing is beginning in our laboratory. We're looking at several different assays. And in fact, it looks like perhaps the best one was developed within our Reagan Institute by Bruce Walker and his colleagues. So we have a number of studies going on to figure out how best to utilize it. I think there's interest in looking at certain populations like the people of Chelsea to better understand how widespread this disease is. There's interest in using it to identify people who could give their serum to others in the hopes that that the antibodies in the serum of people recovering from the disease might help people who are currently suffering from the disease. So there's really no antibody test on the market that's ready for prime time, but we're studying a number of them and hope that we will be using them clinically in the not too distant future.
Yeah. So David, given your position, what are you learning about what the Massachusetts community system is lacking in terms of preparedness for a future epidemic or pandemic, and who should convene to begin this thinking?
Well, that's a great question. And I would say that I've been impressed throughout the pandemic response how well prepared we are, relatively speaking, as a healthcare system. We have a large community of people in my position, a listserv of chairs of emergency medicine departments across the country, and I have not really found a single healthcare system that's been as well positioned as ours, both in terms of coordinated response, preparation, and the ability to expand capacity as we have shown. Still, that despite all that, we will, I think, although we will have enough capacity to meet the demand, it will be close. And so there will certainly be a lot of lessons learned here about how better to communicate across our system, how better to coordinate the assets of a multi-hospital system, and also how better to coordinate across systems to take care of a region, because this isn't really a Mass General Brigham issue or problem. This is an America problem, and for those of us in New England, it's a regional problem. We need to meet the needs of the whole community, not just the ones who get care traditionally in our healthcare system. I think we have a number of leaders at all levels of this institution who are already engaged in those kind of discussions with government leaders, and I expect that those conversations will continue not only as we think about how to reopen our society, but also how we envision something that might even be more dangerous in the future.
And Britt, I would just add that there are tons of heroes at the hospital that have responded to this epidemic, but I just want to single out two. One is Ann Prestipino, one of our senior vice presidents, who's been the incident commander during this episode and has done just a magnificent job. And the other is a physician that David has helped mentor and develop, named Paul Bittinger, who is the division chief of emergency preparedness within David's department, is co-leading our efforts with Ann, and is also the physician that our state and sometimes our federal government calls upon for expert advice. So the two of them have been truly remarkable.
Yeah, I certainly agree. I can hardly endorse that. So Peter, it's just about 5 o'clock, and I'm going to turn things over to you for any wrapping up comments.
Thank you, Britt. And I just want to again thank you all for joining us this afternoon. I hope this session has been informative, instructional, and I hope inspirational as well. I want to thank David and Joe and Joan for joining me on this panel discussion, and thank all of you for standing behind us and making this response that we're engaged in possible. Like I said, we're hoping that we're at near the top of this curve, but we won't be sure until we're over it. And as we've discussed, this dealing with this problem is not going to go away at the end of April, the end of May. Dealing with it is going to last much longer than that. And so having supported the people listening in on this webinar behind us will be incredibly important going forward. So hope you're all feeling well, your families are well, that you stay that way. And if you need anything, please let us know. And again, we can't thank you enough for your support. Thank you.